and we should be all set.
Okay, good afternoon, everybody. Thank you to the Pulmonology Department and Dr. Bradley for inviting me to speak on the imaging of pulmonary sarcoidosis. So I have no relevant disclosures, and my aim is to broadly talk about the definition and, more importantly, describing the radiological abnormalities that we see as radiologists. So without further delay, I'm just going to start off. So what is sarcoidosis? It's a systemic granulomatous disease of unknown cause that primarily affects the lungs and the lymphatic system. Diagnosis is based upon the association of compatible clinical and radiological findings and histological demonstration of non-caseating granulomas and exclusion of other granulomatous disorders. That can sometimes be a little tricky for us. So the modalities that we primarily utilize are chest radiography and CT. Now, chest radiography is abnormal in about 90% of the cases. And the commonest abnormality we see is bilateral non-compressive hilar lymphadenopathy that is seen in between 50 to 80% of the cases. So you might see this abbreviation BHL on some of my slides, so that just represents bilateral hilar lymphadenopathy. So in patients with sarcoidosis who have enlarged lymph nodes, BHL or bilateral hilar lymphadenopathy is the most common pattern that we see. It's seen in almost 95% of the cases. Now, another pattern that we can sometimes encounter is right paratracheal and aortopulmonary window nodal enlargement, which is seen in about 70% of the cases. Anytime you see unilateral hilar or mediastinal nodal enlargement without a bilateral or symmetric distribution, you should consider alternate diagnoses, as in, you look for a lung mass or look for metastases. It could be metastases from an unknown primary, or sometimes it could be representative of lymphoma. So here's a chest x-ray that I've got up, and the arrows basically represent enlarged lymph nodes. And you can see the hilar are not very distinct, and it's quite significantly enlarged. And here we actually have enlarged bilateral hilar nodes. This arrow on top represents a right paratracheal node. The AP window actually does not look abnormal in this case, but in addition to the hilar nodes, there's also parenchymal disease. So this is a commonly used classification. I think it was originally described by Scadding. Now, in this classification, you'll notice that up to 10% of patients with sarcoidosis may have no radiological abnormalities. The commonest radiological abnormality is just bilateral hilar lymphadenopathy, which is the first image, image A. The second one is lymphadenopathy with pulmonary infiltrates, which is B, and that's seen in about 25 to 30% of the cases. And lastly, we have only pulmonary abnormalities, pulmonary parenchymal abnormalities. Here you can see mid and upper lung predominant. There's clearly some fibrotic changes, but the hilar nodes or the mediastinal nodes do not look enlarged. So this is not very common, where you just have isolated pulmonary parenchymal involvement. And then lastly, where you have chronic fibrotic changes. Initially, it's at presentation, maybe only about 50%, about 5%, but then it can be seen in up to 25% during the course of the disease. So this example, which I just showed you, would technically be a stage 2 disease because it has both lymphadenopathy and pulmonary infiltrates. And this example I'm just showing you is essentially stage 4 disease. I can't appreciate the nodal abnormalities significantly, but you can see the quite marked fibrotic changes. So here you can see this upper lung and mid lung predominant disease. There's bilateral hilar elevation due to the significant fibrosis and volume loss from the upper lobes. And when we sometimes see that, we also see this sort of juxtaphrenic tenting along the diaphragms. You can see it here at the right hemidiaphragm, where when you have fibrotic scarring in the upper lobes, you have volume loss that causes the diaphragm to be pulled up or tented up. So parenchymal infiltrates are seen in about 25% with a predilection for the upper and mid lungs. That's a very important finding. So anytime we see upper and mid lung predominant nodular or fibrotic disease, we're thinking sarcoid is always one of our big differential considerations. The other major differential considerations we have is hypersensitivity pneumonitis. Now, keep in mind that with sarcoid, with pulmonary sarcoidosis, we rarely see marked mosaic attenuation or air trapping. Now in sarcoid, sorry, I meant with hypersensitivity pneumonitis, we tend to see mosaic attenuation and air trapping and centrilobular nodularity. With sarcoid, air trapping is recognized, and the literature says that it can be seen in up to 80% of the cases. In my personal experience, I would say it's not as much. The other things to keep in mind is the micronodular or reticulomicronodular pattern, again in the upper and mid lungs. Pulmonary fibrosis is seen in chronic disease, and typically there's architectural distortion that we just talked about, the upward hilar retraction, the linear bands, and then you can see masses bully in advanced disease. So chest X-ray as a diagnostic aid, it's pretty good in early disease, but not great for stage 3 and stage 4 or 0 disease. Now, bilateral hilar lymphadenopathy, when you see it in the context of other problems as in anemia, proliffusions, and anti-mediastinal mass, peripheral lymphadenopathy, or hepatosplenomegaly, consider alternate diagnoses. As a prognostic aid, chest X-ray, there's an inverse relationship between the stage of presentation and the probability of recovery. You can see stage 1 disease, patient clearly does better than stage 3 or stage 4 disease, and chest X-ray is not a great tool for monitoring treatment response. Now let's go over to CT, particularly HRCT. Indications for HRCT in the context of sarcoid. I got this from the ATS guidelines. This is an older ATS guidelines. I looked at the most current ATS guidelines. I couldn't find any mention for indications. Now, if I'm missing something, please let me know. I'll be glad to kind of make the changes. Indications for HRCT, atypical clinical and or radiographic findings, normal chest radiography, but clinical suspicion for sarcoidosis, or for the detection of pulmonary complications. We typically do an HRCT. Now, an HRCT for the trainees is a non-contrast study. We typically do an inspiratory acquisition, and these are helical volumetric acquisitions. So on this, there's basically, we tend to have no interslice gap, and that enables us to reconstruct in both sagittal and coronal ray formats. It's accompanied by an expiratory acquisition, and that tends to have an interslice gap, and that's primarily to look for air trapping. And then prone imaging is there as part of our HRCT protocol, but sometimes if we don't think it's necessary, if we're not looking to exclude dependent atelectasis or extreme basal disease, we won't do the prone images. And with sarcoid, we frequently not have to necessarily do the prone images. What are the main findings? Again, lymphadenopathy, as we talked about on chest X-ray. The most commonly involved nodal stations in decreasing order of frequency. You can see 4R, 10R, so right lower paratracheal, right hilar, subcaninal station 7, station 5, which is the AP window, and then right and left interlobar. Now, there are other instances of fibrotic lung disease or connective tissue diseases where patients can present with pulmonary parenchymal findings, where you can see enlarged lymph nodes. But then if the lymph nodes have this characteristic distribution and tend to be more than 20 millimeters in short axis, then our sort of assessment that this is sarcoid increases. Now, calcification is frequently present at first diagnosis in 20% of the cases, and it can increase to 44% as time progresses. Eggshell calcification is something that we frequently talk about to our trainees. It's in only about 9% of cases. The other instances of eggshell calcification is silicosis, and then we rarely talk about sort of treated lymphoma. So here's an example of a chest radiograph that again shows enlarged bilateral hilar lymph nodes, and the right paratracheal node is also enlarged. You see the frontal and lateral view. In the lateral view, we talk about the sort of donut where the airway is kind of encased by enlarged lymph nodes, hilar lymph nodes. And this is the accompanying soft tissue window of the CT, which shows the enlarged bilateral hilar lymph nodes with both, you can see both hilar nodes are enlarged and the subcarinal node is enlarged too. And there is also a parenchymal abnormality, which I'll talk about next. The most frequent parenchymal abnormality we see is micronodular opacities in a perilymphatic distribution. These are seen in between 80 to 100% of the patients. So pretty much most of the patients we see will have some form of this. They tend to be in a peribronchial and perilymphatic distribution along the pleural surface. Again, mid and upper lung predominant. Now you'll hear me say this multiple times because as far as we're concerned, we're frequently, we may not get a lot of clinical information. And when that's the case, if I were to see this, if I were to see an upper lung predominant pulmonary parenchymal process, and if there's not much suspicion for infection, then at that point, sarcoid is clearly pretty high up on my differential considerations. Now, it can result in a beaded appearance to the fissures and the interstitium, and it's important to distinguish that from lymphangitic spread of tumor. And I'll tell you how we try to approach that. Now, this is a pretty classic example of micronodular pattern, and here you can see along the peribronchovascular interstitium, you can see a lot of tiny nodules that are kind of studying. And if you also look along the pleural surfaces, you can see multiple tiny nodules. This is at the level of the carina, and this is clearly fairly typical. This is actually the lung window of this same patient. It's just at a slightly lower level, slightly upper level. And this is, I'd say, almost pathognomonic. If I were to see this, I really wouldn't consider anything else. Now, this is somebody with lymphangitic spread of tumor. How would I differentiate the two? So for a start, I'm seeing a lot more lines than just nodules. Secondly, it's bilateral, it's symmetrical, and this is in the lower lobes. Sarcoid doesn't frequently affect the lower lobes. Having said that, never say never. There's always going to be an exception, and also I'm looking for other signs. Now, if I had bilateral hilar lymph nodes, as in this case, subcarinal node, and if I were to find out the patient was either from Africa or was of that descent, then I would be considering sarcoid. Now, in something like this, I would probably not put sarcoid as my first differential consideration, purely because of the distribution and just the fact that I'm seeing much more lines than just nodule. But even here, you see the sort of beaded interlobular septum. The other abnormality I'm looking for are nodular and alveolar opacities. These are typically small nodules that can coalesce into larger ones or masses and rarely cavitate. So the alveolar or pseudo-alveolar patterns are seen in 12 to 38%, and they can measure anywhere from 1 to 8 centimeters. Again, the distribution, mid and upper lungs, along the bronchovascular bundles or subpleural regions, just like the micronodules we talked about on the prior slides. And this is what it can look like. Again, here you can see these large masses in both low, upper and mid lungs. It's at the level of the carina, and on the left, this mass is cavitated. You can see smaller micronodules, and these typically are forming due to coalescence of these small micronodules. And the micronodules are basically representative of the pathological entity of granulomas. Some other variations of this is what we call the Sarcoid Galaxy and the Sarcoid cluster sign. In the Sarcoid Galaxy sign, you normally have an irregular large nodule, and these are encircled by a rim of numerous tiny satellite nodules. And another sign to keep in mind is the cluster sign, where you have small clusters of nodules, but they do not coalesce to form a larger nodule. So this is what the Sarcoid Galaxy sign looks like. And if you think about it, it looks like the galaxy. Some people would say this also looks like the halo sign, where you have a central nodule with the surrounding ground glass, but I think the galaxy description fits this better. So here you see a Sarcoid Galaxy in the left upper and right upper lobes. And this is the cluster sign, where you see tiny micronodules, almost looks like ground glass nodules, but since they don't coalesce together, they look more loose and ill-defined. Other signs to look for are ground glass opacities, and these can be seen in anywhere from 16 to 80%. And they also result from confluence of multiple micronodular granulomas and fibrotic lesions. Again, upper lung predominant, multifocal, and when associated with micronodularity or enlarged lymph nodes, think sarcoid, because ground glass is a very non-specific finding and can be seen in a multitude of cases. So in this case, you can see the upper lung predominant ground glass. It's peribronchovascular. And here you can see fibrotic changes because there's also established traction bronchiectasis. In addition to that, I'm also seeing some tiny micronodules. So this was actually pulmonary sarcoidosis. Now, scarring and fibrosis, again, well recognized, more commonly in stage 4 disease and can be seen in up to 50% of the patients. Now, this frequently causes abnormal displacement of the hyla, fissures, bronchovascular bundles, and secondary pulmonary lobules. What we're looking for is upward elevation of the hyla, posterior displacement of the main or upper lobe bronchus with associated volume loss. And these are frequently associated with conglomerate masses that kind of encompass the bronchi and vessels. So this is an example of that. So this is soft tissue windows. You can see the enlarged subcarinal and hilar lymph nodes with this peribronchial mass that's encasing the bronchovascular bundles. And this is what it looks like on lung windows. Now, with scarring and fibrosis, the other patterns of disease, we just talked about the bronchial distortion, which can be seen in up to half the patients. You can have honeycombing with 29% with UIP on histopathology in a linear pattern. So this is a case I saw just last week over here. This is a patient with confirmed pulmonary sarcoidosis. You can see the established honeycombing with traction bronchiectasis, and on this coronary format, you see the traction bronchiectasis honeycombing and the upward hilar displacement that comes from this volume loss and scarring. Now, airway involvement has been described and is seen in 65%. And again, on CT, we see it. I must admit, I haven't seen it as often as the literature says it exists. And we're looking for extrinsic or intrinsic stenosis. Traction bronchiectasis we see when there's established fibrosis. Now, mosaic attenuation with air trapping can be apparently seen in almost 83 to 98%. I must admit, anecdotally, my experience has not been that high, but this is what we're looking at. So in this patient, you can see all the micronodular changes, the alveolar masses, and in this case, you can see the superior segmental bronchus is quite markedly narrowed. And then complications, I just thought I'll mention one of the common complications, but it's important to look for is mycetoma formation. In chronic stage 4 sarcoidosis, once you have established fibrosis and honeycomb and cyst formation, some of these can get colonized and you can have mycetomas. And this is an example of that. You see this chest X-ray, you can see the soft tissue density mass within the right apical cavity, you see the left apical cavity, and on this prone acquisition, you see a mycetoma. I haven't gone through every single complication just in the interest of time, but to kind of summarize the common findings we're looking for in a patient or suspected patient with sarcoidosis is bilateral hilar lymphadenopathy, presence of upper and mid lung predominant disease, and it can be micronodularity, coalescent masses, and then chronic disease with architectural distortion, scarring, fibrosis, honeycombing, and lines. That kind of summarizes the findings. I'm going to stop now, and in case anyone has questions, please feel free to ask.
Thank you, Dr. Bamundi. That was excellent. I had one question.
Sure.
Many times, we'll be asked to evaluate somebody who has asymptomatic pulmonary disease, and one of the questions is, can we get a biopsy of the lung? In those settings, what do you think would be the best imaging choice for them, either non-contrast CT, CT with contrast, or a high-resolution CT?
Now, from my experience, I very rarely ask for contrast-enhanced CT in the setting of sarcoidosis, unless I'm concerned, unless somebody say presenting with sudden hemoptysis, then I might consider getting a contrast-enhanced CT. Or there is significant pleural disease, which I forgot to discuss. So pleural disease is uncommon. Pleural effusions are seen in less than 2% of the cases. So with as far as assessing lymph nodes are concerned, you can see it on a non-contrast CT or an HRCT. So I think an HRCT would probably be my bet to assess both the pulmonary parenchymal findings and also the lymph nodes. Now, when you mentioned biopsy, were you referring to like an EBUS or an endobronchial biopsy?
Yeah, either that or getting a transbronchial biopsy.
Transbronchial biopsy. Well, to be honest, other than a low-dose nodule CT, all of the above that you asked will certainly help in assessing the lymph nodes. Obviously, with intravenous contrast, you have a small risk for contrast-induced renal disease and contrast-induced allergic reactions. With an HRCT, those risks don't exist. But again, it just depends on the situation and what you're looking for.
No, thank you, Dr. Mvundi. I really appreciate it, and I think we'll move on to our next discussant with Dr. Rambatla. So thank you very much for your time.
You're most welcome. Thank you, Patrick.
Hi, good afternoon, everyone. I'm just going to share my screen. If you could give me 1 minute. Let me see. All right, Daniel, can you see that screen? Okay.
Correct. Yep, we can see it and we can hear you pretty well.
Okay, perfect. Great. Good afternoon, everyone. I just wanted to start out thanking Dr. Bradley for inviting me. I'm happy to come, and I see some familiar names on this list, so thank you for helping take care of patients for me, and with me rather, and answering my questions when I pester you. I am the APD in the dermatology department, and today I wanted to talk to you about cutaneous sarcoidosis. I have no disclosures relevant to this talk. I guess my only disclosure is that I have to tell you that I'm by no means an expert on sarcoidosis. We're lucky to have in our department a few of us that manage complex med derm patients, and we share those patients. But I hope that I can enhance your knowledge base today. Oh, it skipped too fast. All right, these are my objectives for today. Patients who already have sarcoidosis and then are one type of patient we get, and then there's patients who were working up for it. And for the purposes of this talk, I'm going to focus on our approach to cutaneous lesions in a known sarcoidosis patients, because those are usually the ones that you're sending over to us. We'll also go through the manifestations of cutaneous sarcoidosis, and then we'll go through some treatment options. I hope I'm not offending anyone with this slide. So some of you may watch the show House, where Dr. House takes on these mysterious cases, and he has a cadre of young interns who offer differential diagnoses. And almost in every show, they go through the room and sarcoidosis is on their differential. And this is sort of a running joke in dermatology, because at our own grand rounds, when we go through the room and we ask our trainees for their clinical differential based on pictures of cutaneous disease, and it's kind of a known thing that if you're a first-year resident and you're stuck, you can always say sarcoidosis. And I think that today's talk will highlight that for you. So let's start off looking at the dermatological approach to cutaneous lesions in a sarcoidosis patient. We know that skin involvement is seen in about 1/3 of patients with sarcoidosis, and it can sometimes be the first clinical sign of disease. And we do have both specific and non-specific skin manifestations, which we will go through. We're always asked, when is it okay to refer to dermatology? And I would say it's always okay to refer, because sarcoidosis really is the great mimicker in skin disease. So we can help confirm the diagnosis and really offer a multidisciplinary approach to treatment. When we think about cutaneous sarcoidosis, there are both specific and non-specific findings. The specific findings are when you see the non-caseating granulomas in skin biopsy, and the non-specific findings are lesions that develop from a reactive process without granulomas. The one that you're most familiar with is likely Erythema Nodosum. So if someone comes over to us, one of the first things that we may offer them is a skin biopsy. Oftentimes we need to take very little skin, a tiny 4 millimeter punch is enough. Sometimes we do need to do excisional biopsies for deeper processes to confirm sarcoidosis and, more importantly, to rule out other etiologies. And this is our tiny punch. When we do the biopsy, this is what we see in our specific sarcoidosis lesions, non-caseating epithelioid granulomas, usually without surrounding lymphocytic inflammation, and we call them naked granulomas. So next, I want to go through some manifestations of cutaneous sarcoidosis. And, these are all of the variants, and it's an exhaustive list. You can see there are so many types of sarcoidosis. But I think that to make this, if I was there, I wish we could make this more interactive, but you'll have to call out the answer or say it in your head so that we can still be somewhat interactive for this next portion. So we'll go through this whole list in a little bit of a different way. I'd like to play a game with all of you. So what I'm going to do is I'm going to give you 2 photos and I'll give you the differential diagnoses. And I'd like you to pick which one is the sarcoidosis variant and which one is not, okay? And I'm sorry, in this view, I can't see the chat, so you'll have to call out if there's any questions. All right, let's start with this one. So one of these patients has syringomas and the other one has papular sarcoidosis. Syringomas are benign, they're non-cancerous growths caused by overactive sweat glands, and those we just treat, essentially it's cosmetic, it's with electrosurgery or laser, okay? This one is the papular sarcoidosis patient, right? So you can see how similar they are. So this is something that we would have biopsied to confirm and make sure that we're not missing something else. All right, next we have one patient with acne keloidalis nuchae and the other patient with papular sarcoidosis. So acne keloidalis nuchae is a form of chronic folliculitis that can cause hair loss. It's usually seen on the nape of the neck, and we would treat it with steroids, antibiotics, laser treatments, things like that. This is papular sarcoidosis. So you can see on the nape of the neck, it's pretty difficult to distinguish from AKN, and this is, perhaps a form of scar sarcoidosis. All right, so this one is a little bit tougher. So one is Tinea corporis and one is Annular Sarcoidosis. If this walked into our clinic, the first thing that we would do is actually a potassium hydroxide prep to see if there's any spores or hyphae to help us figure out if this is fungal. And if it's negative, then perhaps is the time that we would go to a skin biopsy to rule out other annular lesions like granuloma annularia, and there's, we've got a differential for that. So if you picked this one, you were correct. This is Annular Sarcoidosis, and the other one was Tinea corporis, which we would have treated with a topical or systemic antifungal if it was involving hair follicles. Let's move on to the next one. What you see up here on the left, so this is what we in dermatology called leonine facies, and in this entity, it's a face that looks like a lion, and this has a very specific clinical differential diagnoses, and some of them I've listed here at the top for you. So leprosy, cutaneous T-cell lymphoma, amyloidosis, scleromyxedema, and then the last is sarcoidosis or lupus pernio variant of that. So one of these is sarcoidosis and the other is not. If you picked this one, you were correct. This is pretty advanced lupus pernio with bilateral symmetric indurated, really brownish red plaques that are confluent across the malar area. There's some areas on the right cheek which are really more bound down. You see this sort of bulbous nasal deformity and involvement of both the nares and into the nasal mucosa, and maybe even some destruction of the left nare here. The other one was actually a type of leprosy. All right, next. One of these is hypopigmented sarcoidosis, and the other is either hypopigmented mycosis fungoides or vitiligo. So if this is hypopigmented mycosis fungoides, that's a type of cutaneous T-cell lymphoma, and that has a completely separate workup and management. Early vitiligo, which is where you see depigmented patches on the skin, can start off hypopigmented, where it's just a little bit of loss of color, not completely. So this was the hypopigmented sarcoidosis patient. All right, moving on. In this case, we have psoriasis versus Psoriasiform sarcoidosis. In both the pictures, you can see these thin erythematous plaques with scale. Some of these are what we may call guttate plaques, right? So really small lesions. Interestingly, there's actually a case series of patients with concomitant sarcoidosis and psoriasis, which suggests that there is a potential overlap in the immunology and inflammatory patterns that underlie these diseases. And if this patient had both, perhaps methotrexate or a TNF inhibitor would be a good option. But let's see which one. So this one was Psoriasiform sarcoidosis, and the other one was psoriasis. Next, we have lichen planus versus lichenoid sarcoidosis. Lichen planus is an inflammatory skin condition where you see these sort of violaceous, polygonal, flat-topped papules or plaques on the skin. In skin of color, they can look a little bit more erythematous or pinkish, but classically, they're a little bit more violaceous. This is the patient who had the lichenoid sarcoidosis. All right, which one is warts and which one is verrucous sarcoidosis? If this is a wart, we have an armamentarium of treatment options for warts, so we can definitely treat that. If it's sarcoidosis, obviously we take a different approach. This was the verrucous sarcoidosis, and sometimes these can be multiple, so it can be tricky to elucidate without a biopsy. All right, we have rosacea versus Angiolupoid sarcoidosis. We know that rosacea is a chronic condition which causes facial erythema, telangiectasias, inflammatory papules and pustules. They can have a tendency for facial flushing. They can have ocular symptoms. Angiolupoid sarcoidosis, we think that about 8% of patients with cutaneous sarcoidosis can present like this, and it presents as plaques with hypopigmentation and really prominent telangiectasias, and this tends to occur preferentially on the face or the ears or the scalp. This one was the Angiolupoid sarcoidosis. All right, this one, nail lichen planus versus nail sarcoidosis. So both of these patients you can see have onycholysis where the nail's lifting off of the bed. The cuticle is getting destroyed. In this bottom picture, we call that pterygium, and it's scarred. And you can see significant dystrophy in both the pictures. So this was the nail sarcoidosis. And one of the clues in this one is that this patient actually has sarcoidal dactylitis also. And nail changes in sarcoidosis can be brittleness, it can be onycholysis, it can be sort of the subungual hyperkeratosis where they have stuff under there. You can see clubbing, pitting, really you can even see paronychia, which is inflammation along the nail folds with nail fissuring. Nail involvement, we think, is really a marker of more chronic disease, and it can be accompanied by phalangeal bone disease, which then can be associated with intrathoracic sarcoidosis, which you all see. And this more severe form where they have that bulbous swelling of the fingertips has been associated with lupus pernio also. All right. One of these pictures is granulomas reaction tattoo ink, and the other is sarcoidosis. So I'll give you a sec to pick one. This is sarcoidosis within a tattoo. When patients have sarcoidosis that develops within scar or type of trauma, they will have non-caseating granulomas that are seen in the biopsy versus seeing granulomatous foreign body reaction in a scar. And one of the clues in this one is if you see this tattoo, you can see all of the granulomatous change really is in the red color of the tattoo ink, and that's very common. Cinnabar is used in red tattoo ink, and that can often elicit a tattoo reaction. So we do look at the color too as a clinical clue. This one I think everyone on here is probably familiar with. This is Erythema Nodosum, right? You see these tender erythematous subcutaneous nodules, most commonly seen on the leg. It's the most common non-specific lesion that we see in sarcoidosis, and it can be seen in up to 25% of cases. often it's associated with more transient disease, and it may not even need therapy. You all are probably more familiar with acute sarcoidosis, where you can have Nodosum, the hilar lymphadenopathy, fever, arthritis, uveitis, which we refer to as Lofgren syndrome. Often when we see this, they spontaneously resolve, and they don't usually require a biopsy unless they're atypical. Sometimes we'll use corticosteroids in these, and we usually don't have to do too much, but they are self-resolving. We tend to use more, treating the underlying disease, and just bed rest, elevation, and NSAIDs can help. If they are more refractory, we do have things that we can try, obviously. All right. And finally, we'll go on to some of the treatment options that we have. So this is our treatment armamentarium that we use in dermatology. We usually start off with topical steroids for cutaneous disease. Obviously, if our patients have multi-system disease, we're coordinating with you, with pulmonology, cardiology, because their pulmonology and cardiology symptoms and involvement really can take precedence. I would say that our toughest cases probably are the ulcerative sarcoidosis cases, because often they have the multi-system disease, and we struggle with keeping infections under control in the setting of immunosuppression to control the sarcoidosis. And we do have patients who only have cutaneous disease, and their other organ system involvement is quiescent, and that's when we really take the reins on skin disease. We use anti-malarials quite often, and they work very well. Hydroxychloroquine is the one that we most commonly use, just because of ease of getting it and getting insurance coverage, and it has less retinopathy risk than the other anti-malarials. Chloroquine is one that we can use also. Tetracyclines can be used in patients who have contraindications to immunosuppressants. They don't work as well, I would say, but it is something that we have at our disposal. Immunosuppressants, methotrexate is the one that we use most commonly in skin, and it works very, very well. When patients are taken off of it, though, they can relapse, which really suggests that it is more suppressive for skin sarcoidosis rather than curative. And there are some studies that support this. The most recent one I saw had about 40 patients, and when patients were taken off of it, 34 of them relapsed. And then finally, mycophenolate mephitil we use, thalidomide. It's a little bit harder. We have to enroll the patients in the STEPS program, and it's a little bit more difficult as far as getting the pregnancy test on time and prescribing what we do have that if we need. And then the TNF alpha inhibitors are probably the most common one that we use once they start to have more involved skin disease. So I think I've convinced you today it's always sarcoidosis, right, with our differentials. I hope that you can take something away from today's talk. So thank you, and I can take any questions.
Thank you very much, Dr. Mbala. That was great to see, and I appreciate the examples. The one question I had is, do you see a lot of the relapse in the use of hydroxychloroquine, or is it really most of the time with the DMARD therapy?
It tends to be more the DMARD. The hydroxychloroquine, we almost never take them off of it. It's such, in dermatology, we use it for so many of our skin conditions, and it works so well. So oftentimes we'll have patients on it for a few years before we want to take them off, especially once it's gotten things under control. So I would say if it's really quiescent, we would do a trial of it. But in my experience, oftentimes they tend to stay on it for quite a few years.
Okay. Thank you.
Any other questions? All right, thank you so much. I'm happy to, if you want to email me anything, reach out. I'm happy to answer questions. Thank you for having me.
Thank you very much. Appreciate it. And so next we have Dr. Aurora, who's going to talk about the modern workup of cardiac sarcoid.
Thank you, Dr. Bradley. Can you hear me?
We can.
Okay, wonderful. Let me just share the screen. All right. So thank you for inviting me to speak. My name is Lindsay Aurora, one of the second-year cardiology fellows. I'm joined today with Dr. Ananth as well, who will be participating in the discussion. So today I'll be speaking about the diagnosis of cardiac sarcoid and briefly touching base on management as well. So let's get started. So just to start with a little bit of background, as you're aware, sarcoid is a diagnosis of exclusion. There's no reliable biomarker for establishing diagnosis or disease monitoring. Non-necrotizing granulomas are considered an essential feature of the disease, but these findings are not specific to sarcoid, right? They can be seen in numerous infectious inflammatory diseases. Cardiac and pulmonary involvement in sarcoid is associated with a greater mortality than other manifestations of the disease. And when we are diagnosing this condition, we should consider the presentation, the histological evidence of granulomatous inflammation, and exclusion of other alternative granulomatous diseases. Now, cardiac involvement in sarcoidosis has been reported in about 25 to 58% of autopsy studies, with highest prevalence described in Japanese cohorts, with the greatest greater involvement usually resulting in more symptoms. So patients or granulomas in cardiac sarcoid can be found anywhere in the heart, more commonly in the left ventricle and the intraventricular septum. Disease manifestations classically depend on the location, extent, and stage, and symptoms can include conduction abnormalities, arrhythmias, less commonly heart failure, but patients can present with syncopal episodes, pre-syncope palpitations. Your arrhythmias can range from a right bundle to varying degrees of AV block. And both AV blocks and history of ventricular tachycardia increase the risk of sudden cardiac death. And oftentimes, sudden cardiac death can be the first and only manifestation of the disease, which accounts for as much as about 65% of deaths in some studies. Right ventricular involvement in cardiac sarcoidosis is quite common. It ranges from 6% to 65% depending on the study. And this can be reflective of either the direct granulomatous disease of the right ventricle or hemodynamic sequelae of longstanding left ventricular cardiomyopathy or even pulmonary hypertension. Nevertheless, the presence of RV involvement, as you may imagine, is considered a marker of poor outcome. RV late gadolinium enhancement seen on cardiac magnetic resonance imaging, or MR, has been shown to be predictive of an increased risk of ventricular arrhythmias. And more so, RV dysfunction secondary to pulmonary hypertension is typically seen in patients with extensive lung fibrosis, although this can also be seen in patients with normal lung architecture. There's surveys in sarcoid clinics that have identified pulmonary hypertension in about 5 to 20% of cases, with up to about a half of these persistently dyspneic patients that are associated or that are diagnosed with having sarcoidosis-associated pulmonary hypertension. Now, isolated cardiac sarcoid, so that is essentially in the absence of any extracardiac evidence of the disease, also has a high prevalence of about 27 to 54%. The Japanese studies have identified cardiac sarcoid as a leading cause of mortality, especially in their population, with about 85% dying from cardiac complications. Now, there are more recent reports that are saying, is there a better prognosis? There's a group out of Finland that looked at outcome of 110 Finnish patients, and these were biopsy-proven cardiac sarcoid, and they found that with the current available therapies, patients with cardiac sarcoid did much better than anticipated. And specifically, the 10-year likelihood of transplantation-free survival was 83% overall, and 91% in patients receiving immunosuppressive therapy. However, despite all this encouraging outcome data in cardiac sarcoid, determining prognosis still remains challenging, and it's mostly based on traditional outcome metrics. So we look at our left ventricular dysfunction, history of malignant arrhythmias, or extent of late gadolinium enhancement on MR. And again, with this, the late gadolinium enhancement showing superiority to standard prognostic parameters as compared to ejection fraction or cardiac volumes in predicting adverse outcomes. And similar issue in cardiac pulmonary sarcoid that comes up is the availability of a biomarker or cluster of biomarkers with any prognostic power, which is a missing piece in this diagnosis. I mean, there are biomarkers such as BNP and high sensitivity tropes and interleukins that are often elevated in patients with cardiac sarcoid, but these tests do have low sensitivity and specificity. There are current immunological markers such as amyloid A proteins, microRNAs that are currently being investigated, but none that can be readily used right now to diagnose or assess disease activity. So getting started on the diagnostic approach. Now, endomyocardial biopsy is the gold standard to establish diagnosis, but it does have a very low sensitivity, less than 25%. And this is due to the patchy or focal distribution of the granulomas, which results or can result in a sampling error. So the thought is imaging or voltage guided biopsy procedures are known to shown to increase success rates to about 50%. So essentially, we're using imaging as a guide for the biopsy to increase the diagnostic accuracy. The voltage guided biopsy, that's essentially the utility of electroanatomic mapping to guide our biopsy. The hypothesis is that where there's abnormal or low voltage electrograms, that'll signify your underlying scar tissue. And those areas with fragmented signals without any isoelectric segments are perhaps to show or likely to show active disease. But without confirmatory tissue diagnosis, we can use clinical guidelines with proof of extracardiac disease that's commonly used. Now, there is the Japanese Ministry of Health and Welfare criteria that was initially published in '93, most recently modified in 2007 and 2017. And this combines histological confirmation of extracardiac sarcoid or with a combination of some major and minor criteria. Now, the revised 2017 document is from the Japanese Circulation Society Joint Working Group, and that includes PET and MR, cardiac MR, among the major diagnostic criteria for cardiac sarcoid. Now, compared with the Japanese Ministry of Health and Welfare, the HRS criteria, so that's the Heart and Rhythm Society, they are known to have greater sensitivity. This includes PET and MR and responsiveness to steroid therapy. So here is the Japanese Circulation Society and the HRS, and these are currently the two most well-established diagnostic guidelines for cardiac sarcoid. Keep in mind, these are based on expert consensus and have yet to be validated by prospective data or clinical trials, but I want to briefly go over them. So at the top, if you look at the top of both columns, you're starting with histological diagnosis. And then starting on the left, if you look at the Heart Rhythm Society criteria, you're looking at diagnosis from invasive and invasive studies. So it is probable there's cardiac sarcoid if there's, again, histological evidence of any extracardiac disease, one or more of the following. So looking at your therapy or responsiveness to steroids, immunosuppressants, unexplained reduced left ventricular systolic dysfunction, any arrhythmias or high-grade AV blocks, your patchy uptake or a late gadolinium enhancement that happens on a cardiac MR. And normally the pattern of scar detected on MRI with the late gadolinium enhancement is classically described as non-ischemic, and it involves usually the subepicardium and mid-myocardium in cardiac sarcoid. And of course, you're excluding out any other causes for these cardiac manifestations. On the right side with the Japanese Circulation Society, again, we start with the histological diagnosis, and then there's a combination of major and minor criteria, very similar to HRS. You're looking at your high-grade AV blocks, your basal thinning of the ventricular septum or any abnormal anatomy, again, your left ventricular systolic dysfunction, any abnormalities on PET scan, cardiac MRI, or even perfusion defects. Now, initial imaging modalities, ones that are readily available, we can always start out with a chest X-ray, CT chest. You look at your lung and lymph node involvement, mediastinal hydrolymphadenopathy, which is actually abnormal in greater than 90% of patients with extracardiac sarcoid, and of course, high resolution CT. Now, most would not exclude cardiac sarcoid based on negative chest imaging. So we can always move forward and also look at ECGs. So edema, granulomatous infiltration, and fibrosis associated with cardiac sarcoid can result in ECG abnormalities. But again, these are only present in about 3.2 to 8.6% of patients with clinically silent cardiac sarcoid. As briefly mentioned before, the most common findings that you will see would be your degrees of AV blocks of first to third degree premature ventricular complexes or your PVCs, your right bundle, abnormal axis, and Q waves. And again, this can be a trigger for further investigations or to aid with diagnosis. You can always do a 24-hour Holter monitor if there's any concern that can detect subclinical arrhythmias. But again, these studies are also, keep in mind, the EKG and Holter are non-specific and insensitive to get a diagnosis of cardiac sarcoid, but it's part of the diagnostic workup. Then we also have our transthoracic echocardiography, so echoes. So these can be useful. This can be useful in identifying patients with known extracardiac sarcoid that it might have cardiac involvement, even monitoring disease progression. Common findings on echo that we'll look for would be regional wall motion abnormalities, usually in a non-coronary distribution. You'll see anterior basal septal thinning with increased echogenicity. That could be highly suggestive. Aneurysm of the interventricular septum. You can also see other abnormalities such as decreased left or right ventricular systolic, diastolic function, valvular abnormalities, pericardial effusion, and these are present in about a wide range, 14 to 46% of patients with cardiac sarcoid. And again, in isolation, echo lacks specificity and sensitivity because abnormal or a normal echo cannot rule in or out the disease in the absence of a confirmatory biopsy. And then moving on to our advanced imaging techniques. So Cardiac magnetic resonance, or CMR, it's a non-invasive advanced imaging test, right? It offers high spatial resolution. You can see detailed assessment of our left ventricular and right ventricular function. You can see if there's edema, perfusion defects, myocardial scar. Again, it offers high spatial resolution. Acute phase of the disease is commonly characterized by non-coronary distribution wall motion abnormalities. You can see increased myocardial wall thickness, increased intermyocardial signal intensity on T2 weighted images. And that can be indicative of, or that can be because of granulomatous lesions and edema associated with inflammation. And normally your chronic phase or inactive cardiac sarcoid can be characterized by myocardial wall thinning, aneurysm. You can see low signal on T2 weighted images, but you'll see high late gadolinium enhanced signal intensity, which can suggest scarring or fibrosis. So MR, it's, can identify if there's an active disease or if there's chronic or scarring fibrosis prior to pursuing further workup. Now, multiparametric MR imaging with T2 mapping to evaluate for edema, this can prove valuable because you can identify those areas of edema inflammation even before there are detectable changes in ejection fraction or late gadolinium enhancement. But again, the diagnostic accuracy of T2 is unclear. It's undergoing it's uncertain, and it's undergoing investigation. This is some patterns of delayed enhancement on cardiac MR with cardiac sarcoidosis. So 5 patients with different types of cardiac involvement, patient A, B, C, D, E. So A starting in the subendocardium, delayed enhancement that you're seeing. Patient B more so in the mid myocardial. And again, just different ways of what it would look like on a cardiac MR to give you some visual characterization here. Now, PET-CT. So PET is a radionuclide imaging technique commonly used with the CT scan to detect any active metabolic processes in the body. So typically for these protocols, we're using the FDG PET for imaging inflammation combined with SPECT or PET for perfusion imaging as well. Now, again, as I mentioned, this couples anatomical information to identify mononuclear inflammatory cells with a radionucleotide called FDG or fluorodeoxyglucose. And this can identify granulomas. This offers a higher spatial resolution compared with other nuclear imaging modalities. It also has technical advantages. So you have a lower radiation exposure. It has a built-in attenuation correction and quantitative analysis. And the combined sensitivity and specificity is estimated to be at 89% and 78% respectively. Now, FDG, so the cellular uptake of FDG is related to inflammatory cell infiltrates. Just to give you a little bit of understanding of the mechanism of action. So the cellular uptake of FDG in sarcoid is related to the inflammatory cells, as I mentioned. So active inflammatory cells, they have high glycolytic activity. They're satisfying their large energy demands. They produce a lot of ATP. So after crossing the cellular membrane via glucose transporter, so both FDG and glucose are phosphorylated via an enzyme. And while glucose is further metabolized, the FDG, the phosphorylated enzyme, radionucleotide, remains trapped within the cells and it can be imaged. So FDG accumulates in active lesions where inflammatory cells are utilizing energy as utilizing glucose as an energy source. So then active sarcoid lesions in various organs are visualized by increased FDG uptake on PET. So that's kind of the mechanism of how we're visualizing these lesions. Now, PET-CT, it's an essential modality for early diagnosis, management, follow-up, prognostication. There is one study out of a group in Japan that has directly compared the diagnostic accuracy of FDG PET-CT with CMR. PET-CT has a higher sensitivity, lower specificity than cardiac MR. And the capability of PET in identifying an active lesion, so your early stages versus late gadolinium enhancement and identifying fibrosis, your advanced stages accurately, is likely the most likely explanation for differences in the sensitivity and specificity of these two imaging modalities. There's also prognostication that has been studied with these two modalities. There's been both retrospective and prospective studies comprising about 100 to 300 patients. They've shown that patients with focal myocardial perfusion defects and increased myocardial FDG uptake, they have significant risk of adverse events such as arrhythmias or even all-cause mortality. And serial PET-CT scans may be used to determine treatment option and monitor treatment response in patients with cardiac sarcoid. And this is mainly due to the ability to measure and quantify the metabolically active lesion. So there are limitations. The main limitations is the high rate of false positive scans because of inadequate suppression of physiological myocardial FDG uptake. So as you can imagine, special patient preparation is required before these scans to adequately suppress myocardial uptake and increase the utilization of free fatty acid by the cardiac muscle. So normal myocytes utilize glucose as one of their main energy sources, and there's various techniques that have been developed to suppress the physiological uptake. And in the fasting state, free fatty acids take up about or account for about 90% of oxygen consumption of normal myocytes. So the whole goal is to shift this metabolism to fatty acid. And current approaches that we advise our patients: avoiding strenuous exercise for 24 hours, low carbs diet, high fat diet. So everything that goes against the cardiology goal, but regardless, prolonged fasting for 12 hours, and also administration of heparin to maximize the suppression of normal uptake. Heparin is thought, the mechanism is that it activates lipoprotein and hepatic lipases. So that also increases your plasma free fatty acid levels. And this is a table that demonstrates perfusion and metabolism patterns in various stages of cardiac sarcoid. As you recall that I mentioned the radionuclide protocols for imaging sarcoid, you're using your FDG PET for imaging inflammation combined with a Spectre PET myocardial perfusion imaging. So as you start at the top, normal, you don't see a perfusion at uptake, no perfusion defect. FDG uptake is no or low. That is all a radionucleotide in the pool, in the blood pool. There's no focal uptake in the myocardium. And then as you go on, early progressive, peak active, progressive, you see perfusion defects correlating with your FDG uptake. One thing to keep in mind is a reduction in FDG uptake could mean a resolution of inflammation or progression of disease process and fibrosis. If you look at normal and fibrosis and look at the perfusion and FDG uptake, you need perfusion imaging even on the follow-up scans or initial scans to help distinguish, right? Because in your normal, you don't have any perfusion defects and your FDG uptake is no or low, but in your fibrosis, you have severe perfusion defects, even though you do have low FDG uptake. It's just the importance of how perfusion imaging is critical even on follow-up and initial scans. So limitations for this now, although screening for cardiac involvement should be pursued in patients with a history of sarcoid and cardiac symptoms, the approach to patients with a diagnosis of extracardiac disease, but those who are asymptomatic, remains controversial. So because it's uncertain if subclinical disease should be treated, is there more than one subgroup that exists within this population? The Heart Rhythm Society gave a class 3 recommendation to screening for cardiac involvement in patients without symptoms or any evidence of abnormalities on an ECG or transthoracic echo. And some additional limitations of current diagnostic workup also include the qualitative interpretation of the PET-CT scans, which are typically reported as positive or negative, but they do not accurately grade disease severity. And then there's always uncertainty in the setting of a negative scan. I mean, what's the period during which patients remain at low risk after a negative scan? A question that I wanted to bring up that Dr. Bradley mentioned, and I think it's good for discussion, is, how would you manage an asymptomatic sarcoid patient with abnormal ECG findings? So let's say you just have a right bundle, they come to you and no symptoms at all. At this point, the recommendation would be to start with a transthoracic echo and a Holter monitor. Now, if those are negative, no further workup is generally indicated, but you can do an annual ECG and visit to check on symptoms. If there are any abnormalities that you find on a Holter or transthoracic echo, the next step would be a cardiac MRI. And at that point, you can always refer to cardiology for routine follow-up. Now, cardiac sarcoid, in the absence of extracardiac manifestations, the identification can be tricky. As we discussed before, changes on ECG or transthoracic echo, they lack sensitivity and specificity. Abnormal late gadolinium enhancement patterns or MR imaging can be a trigger to consider cardiac sarcoidosis, at least over an otherwise unspecified cardiomyopathy. At that point, it's important to keep in mind other differential diagnoses. So you can look at arrhythmogenic right ventricular cardiomyopathy. Although compared with cardiac sarcoid, the right ventricle is more involved and there is sparing of the septum with no history of conduction abnormalities. You can also think about myocarditis, which can mimic cardiac sarcoid with enhancement happening in the subepicardium mid-wall. But oftentimes, patients with myocarditis usually have a more acute onset of presentation with sometimes a prodrome, which can be viral in etiology, or a more aggressive and fatal course, such as in giant cell myocarditis. Briefly to touch on treatment. So the goals for early treatment, we have 3 goals. So we want to decrease inflammation, prevent fibrosis or scarring, and preserve cardiac function, and of course, reduce our sudden cardiac death risk associated with conduction abnormalities or any ventricular arrhythmias. Treatment can be generally divided into two categories. There's inflammation and the clinical sequelae, which can be arrhythmias or any dysfunction of the ventricle. Among our anti-inflammatory agents, steroids are usually considered first-line therapy, but again, there's no randomized control study that has evaluated their efficacy or even dosing or treatment duration. And most experts recommend an initial dose of 30 to 40. And followed by repeat imaging like PET-CT after 1 to 6 months for response to treatment and assessing what the next dose should be of prednisone. There's limited data to timing of dosage de-escalation. Overall, the general rule of thumb is the earlier the treatment, the better the response. Now, this is like an imaging guided approach for immunosuppressive therapy. Just want to go over this. This is a decision treatment algorithm. It was previously proposed. It's often used in clinical practice. So at the top, we have our prednisone that we're starting. We're repeating a PET scan after 3 months of treatment. If there's no, on the left now, if there's no abnormal uptake, then you can perhaps consider a steroid taper. And then if treatment is eventually stopped, you'll repeat a PET scan 3 months after stopping treatment. On the right side at the top, if there is any abnormal uptake, then you'll usually add a second line of agent if your first initial therapy isn't working. After your PET scan after 3 months, if you decide to stop treatment on the left side of the columns, if you have disease relapse, again, you'll restart your therapy and you'll continue to follow PET. Let's say there's no relapse. You'll still follow the patient with echo and ECG at least, or continue. They should at least be monitored at least 3 years after reducing or stopping steroids, because relapse can occur as much as about 40% of patients. Now, steroid-sparing alternatives, they're usually considered second line. Methotrexate has the most supporting evidence. There's also azathioprine and mycophenolate, but they have been reported as effective, but little to indicate that they're better than methotrexate. And oftentimes, this will depend also on the institution, the provider preference and experience. Because one general rule is a lot of literature out there, so a lot of these cardiac sarcoid patients often require years of therapy. So steroid-sparing agents seem to be a reasonable alternative to prolonged steroid use. So that's another thing to keep in mind. Third line therapy is usually with biologics, and I won't go into too much detail, but just infliximab has proved to be an effective treatment. There's other agents like rituximab and corticotrophin. There is some increased mortality associated with the use of anti-TNF inhibitors or therapy with patients with severe cardiomyopathy. Rituximab has also been used in cardiac sarcoid, also in pulmonary and ocular sarcoidosis. And compared with other agents, there's no associated cardiotoxicity. There's a longer latency to demonstrate benefit, and it is less effective than infliximab. Cardiac devices, so this is one of the last points I want to touch on. So cardiac devices, it's really important to treat these underlying arrhythmias. They have become the standard in symptomatic cardiac sarcoid. For patients with documented ventricular arrhythmias, especially ventricular tachycardia, ICD can be life-saving. And for asymptomatic patients who lack triggers for this ICD implantation, you can do an EP study or programmed electrical stimulation. And that's been proposed for risk stratification based on a study where it was shown to predict event-free survival. And placement of an ICD can provide patients with a safety net while anti-inflammatory therapy is initiated. And this is very important because arrhythmias remain highly prevalent in the first few months of treatment. This is the consensus recommendations for ICD implantations in cardiac sarcoid by the Heart Rhythm Society. So really to start from the top, an ICD or class 1 recommendation is for any spontaneous sustained ventricular arrhythmias, including any cardiac arrest. And if you have an EF, less than 35%, despite being on optimal medical therapy. Class 2A recommendation, if you have an indication for a permanent pacemaker and or any unexplained syncope or even an inducible ventricular arrhythmia. And then class 2B, this is where HRS differs from American Heart Association. My point on the bottom right is that an ICD may be considered, so class 2B here and class 2A with AHA, if your EF is greater than 35%, if there's a scar and an MRI or an abnormal PET scan. And then, of course, at that point, if they don't meet criteria for an ICD, just going down the algorithm on the bottom left, you can consider a cardiac MRI and then base your decision on the presence of any late gadolinium enhancement, any presence of active or disease that's, or any scarring or fibrotic advanced disease. And at the same time, when we're considering all these treatment options or doing this diagnostic workup, we want to continue and initiate standard guideline-directed medical therapy for the management of heart failure. Now, although these therapies may not have a direct effect on sarcoid activity, it's important because you're preserving your ejection fraction, you're improving heart failure-related outcomes. Cardiac transplantation is only considered or should be considered in patients with intractable ventricular arrhythmias, if you have end-stage heart failure, refractory cardiogenic shock. And now all sarcoid can reoccur in the transplanted heart, but the risk of reoccurrence based on some studies is quite low. It's less than 10% when the patient is kept on low-dose steroids. A study that I wanted to bring up was the cardiac sarcoidosis randomized trial. So this is the first international study to be conducted in patients with cardiac sarcoid with goal of obtaining data for treatment. This study started about in January of last year, and its estimated completion date is December of 2024. And they're enrolling subjects who have clinical manifestations of cardiac sarcoid, randomizing them to standard prednisone for 6 months or a combination of methotrexate and prednisone. And just to end things off, as we are all aware, and that's why we have this discussion, sarcoid is a complex disease, right? It has a lot of genetic and environmental factors. I think there's importance of centralizing care and centers of excellence. And there is a need to create international consortia where we have shared goals, protocols, imaging, biobank, metrics of disease activity. And this would help us define specific molecular pathways and targeted therapies, because ultimately our goal is to attain an improved understanding of the disease pathophysiology and standardized treatment across institutions. Thank you.
Thank you very much, Dr. Aurora. That was fantastic and very detailed. Dr. Ananth, I don't know if you had anything to add to this.
No, great job, Lindsay. I just have a couple of points that I wanted to mention. One is the exact clinical significance of presence of FDG PET finding in the setting of a completely normal MRI is unclear. There is conflicting data as to what to do. So unless there is a very high clinical suspicion of active sarcoid, for example, if you find a young person who has an AV block or BT, typically if anybody has those findings less than 60, sarcoid is the leading thought process. And obviously if you do an MR and MR comes back squeaky clean, then we do a PET, then we basically raise the question if PET shows inflammation. In the absence of that, if routinely PET shows a finding, and as Lindsay mentioned in one of her talks, there is an incidence for false positivity. So reading the PET scans in a correct way, patient prep, making sure it's not a non-diagnostic study is important. The other thing also is before treatment is started, I think all patients should have cardiac PET. It's challenging to follow treatment a response with MR, because MR shows fibrosis and there's really no good data to say that fibrosis improves with treatment. And the T2 signal, which is the inflammation signal, is really unpredictable. So we would definitely recommend that all patients who are being considered for initiation of sarcoid treatment, particularly cardiac sarcoid treatment, undergo a baseline PET CT so that PET can be used for monitoring. And in general, I think the first test of advanced imaging choice should be MRI. The spatial resolution of MRI is superior to PET scanning. And so if your MR comes back really clean or no wall motion abnormality, no T2 and no fibrosis, and your suspicion is not extremely high, then I think it's safe to defer further diagnostic workup with PET.
No, thank you for that clarification, Dr. Ananth. We really appreciate it. And thank you again, Dr. Aurora, for your presentation. That was excellent. So next, we're going to have Dr. Gwizdala talk to us about some of the immunologic findings in sarcoidosis.
Yep, just bringing it up now. So yeah, I'm Jonathan Gwizdala. I'm going to be talking today about the immunologic abnormalities in sarcoidosis, also with a brief look of abnormalities with genetics and some environmental and microbial triggers as well. So just a quick overview, we'll go over a little bit of the immunology and formation of granulomas, as well as the continuation of granulomas and inflammation that we see in sarcoidosis, including a quick touch on the thought of the immune system exhaustion that can occur. We'll take a brief overview of possible antigens that can trigger sarcoidosis, as well as take a look at some of the genetics, epigenetics, and mutations that we see that have been associated with sarcoidosis. So just to start with how granulomas occur, so the innate immune system starts, with a foreign body reaction from something that presents itself with an initial mild acute inflammation with neutrophils and then tissue-specific macrophages and monocytes being drawn to the area of inflammation. There's usually then formation of these activated macrophage, then form into multinucleated giant cells that form into the granuloma. And usually this is due to inability for full phagocytosis of the foreign body or infection with further recruitment of T cells and B cells. What we usually see at the beginning of the inflammation is TNF alpha, IL-1, IL-12, IFN gamma, as well as other inflammatory cytokines, bringing PMNs and macrophages, as well as other lymphocytes. And then these then cause activation of the macrophages and T cells to further inflammation in these area. TNF alpha especially plays an important role in maintaining granuloma structure, along with CD4 T helper cells, T helper 1 cells, producing further IFN gamma, IL-2, IL-3, lymphotoxin A, and TNF alpha, which kind of continues the kind of progression of inflammation in the area. Dendritic cells and macrophages during this time act as antigen-presenting cells with presentation of different peptides on MHC class 2 or 1 molecules. These macrophages and granulomas present these to active T cells with the adaptive immune response then starting. During this infection and inflammation, IFN gamma and other cytokines promote T helper cells to go towards the Th1 cellular adaptive immunity pathway, with IL-12 continuing this Th1 response. Natural killer T cells are also recruited in the area with TNF alpha and IL-12, and those also continue to synthesize and release IFN gamma, which continues the cycle of inflammation. Another cell pathway and inflammatory pathway that's seen in this early granulomas and granuloma formation are Th17 cells with IL-17 and IL-23 being produced, which have a pro-inflammatory response for granulomas with overlap of much of the Th1 pathway. But this also continues PMN recruitment in this area to have more neutrophils. These specific cells also secrete IFN gamma as well. And just as an aside, this pathway also has been hypothesized with upregulation causing autoimmunity. So just a quick look in terms of an illustration of this. On the left, we see a macrophage with bacteria binding to it, which is then engulfed, phagocytized with the degradation products of different peptides and DNA, then getting displayed on MHC class 2 molecules as a antigen presentation. In addition, we see with macrophages different secretions of inflammatory molecules as well as molecules that then cause destruction in that kind of localized area. On the right, we see APCs, antigen-presenting cells, with those MHC class 2 molecules and antigen, which further activates T cells, specifically early on with specific co-stimulatory molecules like we talked about with the IL-12, causing further differentiation into the Th1 pathway. And that promotes further macrophage activation, and with TNF alpha specifically with the epithelioid cells into multinucleated giant cells. So with granuloma inflammation, usually you have to at some point have resolution, and that's where these two other pathways come in with T regulatory cells as well as T helper 2 cells. In terms of when we take a look at the reduction of inflammation, we see that a lot of times it's due to APCs and antigens being successfully expressed with switching to the adaptive immunity. IL-10 is usually expressed to decrease the amount of Th1 and Th17 and increase the amount of T regulatory cells and Th2 cells. In terms of the T regulatory cells and T regulatory pathways compared to Th1, it promotes overall decrease in inflammation by decreasing inflammatory cytokines. It also downregulates that Th1 pathway. Usually we see the secretion of IL-10 from Treg cells, which is anti-inflammatory. It suppresses TNF alpha, IL-1, IL-12, IFN gamma. We also see secretion or production and secretion of TGF beta, transforming growth factor beta. And in this case, it's actually seen as an anti-inflammatory with cell signaling, especially in active macrophages, and can cause apoptosis in those activation pathways. Of note, there has been seen increased amounts of Treg cells, likely non-functional, normalized function, which can cause continuous granuloma formation. In terms of this Th2 cells and the Th2 pathway, it differs from the Th1 as it promotes granuloma resolution by stopping macrophages from being formed into those epithelioid and giant cells. And it promotes, again, apoptosis of the granuloma cells and promotion of further repair in the surrounding tissue. These Th2 cells and pathway have increase in IL-4, which actually differentiates B cells to plasma cells. It can also decrease Th1 cell pathways and IFN gamma, and it actually can change activation of macrophages to a repair type macrophage. IL-13 is also produced, which increases MMPs and fibrosis, but also decreases that inflammatory Th1 response. So, pending whatever the inciting reason was for the granuloma, there's either, resolution that can occur, but there can also be some leftover fibrosis in that area due to kind of the destruction of the macrophages in the area. And with that, macrophages in granulomas, they're longer lived, 5 to 12 months. When we see chronic inflammation in these granulomas, there's usually up to about a 1% daily turnover. And when we see long-term turnover in these macrophages with kind of destruction of the surrounding areas due to cytotoxic and MMPs, which digest and destruct the tissue around it, that's where we see a lot of the fibrosis from these macrophages and granulomas. So just as a illustration, we see these macrophages being activated in different ways to basically promote different cellular pathways, as well as having feedback themselves from those pathways to continue these areas of either inflammation or anti-inflammation. As you see on the top left, there's the pro-inflammatory Th1 pathways, as well as the Th17 pathways with PMNs, while on the bottom, we see kind of anti-inflammatory with the T regulatory cells, as well as wound healing with the Th2 cells, and with production of more plasma cells and granulocytes. So how does this differ in terms of granulomas and sarcoidosis? So the original innate immune activation of the macrophages appear to start as normal. However, there's creation of sarcoidosis granuloma, which differs with usually some sort of abnormal MHC or upregulation of cytokines, which directs to a type of phenotype of continued inflammation within the adaptive immune response and continued granuloma. Originally, it was believed that there was deficiency in T cells in sarcoid granulomas back in the 1970s, 1980s. However, further knowledge has showed there's actually increased amounts of specific helper T cells seen, especially in the periphery. The response to these pathways and T cells going down towards the Th1 cellular pathway, which causes continued differentiation of macrophages into epithelioid cells and continued granuloma formation. And this causes, the continued local T cell antigen response to persist. There's also downregulation or impairment in T regulatory cell response, as well as the Th2 cell response. And so that allows a continuous kind of cycle of Th1 and Th17 pathways to continue to produce pro-inflammatory cytokines such as TNF alpha, IL-17, IL-23. In addition, there has been shown in peripheral blood measurements in sarcoid patients of an increased T cell population of CD27 negative cells, which has kind of been considered to indicate likely continued chronic antigen stimulation. So also studies have shown increased amounts of serum amyloid A or SSA, another heat shock protein or HSP within sarcoid granulomas. And this has been hypothesized as causing a decrease in antigen removal, actually even from the SSA itself, as well as continuation of the Th1 local response. SAA has also been seen in other inflammatory conditions such as TB, RA, and sepsis. Um, and there's also been shown that there's some patients with specific phenotypes and populations where the Th17 to the Treg ratio actually plays a role in the continued inflammation and further progression of sarcoidosis. And with that, there's been further evidence that inhaled VIP actually has the ability to increase the activity in T regulatory cells with decreasing activity in other T cells in that kind of situation. There also appears to be NK cell depletion, which has also been kind of hypothesized to point towards continued energy within sarcoidosis as kind of a functional exhaustion with continued incomplete antigen-specific memory response. Further kind of supporting this continued T cell immune response playing a role in the granulomas in this is observation of HIV sarcoid patients who have CD4 lymphopenia leading to remission of sarcoidosis, and then HIV patients with ART therapy who have recovered CD4 counts having a sarcoidosis-like granulomatous disorder or even recurrence of sarcoidosis during immune reconstitution. So just some more illustrations of kind of all that information. On the left, we see this immune response 1, which is more of a normal pathway with appropriate T cell response to the granuloma formation and APC, which then has recognition from the APC and activation of pathways allowing for granuloma resolution. On the right side, which is more the kind of immune response we see in sarcoidosis, shows continued antigen and granuloma inflammation with an inappropriate T cell response from either the T cells, the APCs, or something of a combination with further inflammation and granuloma persistence. And here's kind of a further look also kind of at that with how this likely occurs, with some type of initial inflammatory trigger, which causes the macrophage activation, going into epithelioid granulomatous inflammation, and then macrophages that are presented as APCs with kind of an inappropriate response with the Th1 cells and causes continuation secretions of the cytokines and responses that promote continuation of the granulomatous inflammation. So in terms of going to antigens, why antigens? Why some kind of trigger? Being the antigen being the initial trigger, as well as causing potential continued inflammation, appears to make sense, especially in the initial inflammatory cascade. The original idea for this many years ago was the straightforward thought process of TB and other antigen-forming granulomas, with antigens being phagocytized by APCs and then shown on MHC class II molecules. There's been a lot of prior research with sarcoidosis and biopsies showing remnants of prior infectious microorganisms, especially including Mycobacterium and others such as C. acnes. Prior meta-analysis have showed Mycobacterium were 10 to 20 times more likely to be detected in samples from sarcoid patients and also has prior associations with sarcoidosis. However, given ability to not have infectious etiologies found on biopsy with patients with sarcoidosis, as well as patients being on immunosuppression therapy without relapse of infection, point against active infection being the main reason. In terms of other environmental or non-microbial factors for potential triggers, there's been a lot of both sarcoid or sarcoid-like disease associations with different organic and inorganic exposed populations. There's actually seen in terms of with combustible wood products, increased incidences in workers such as firefighters compared to other emergency medical personnel not exposed to have higher association with sarcoidosis. In addition, first responders showed an increase in sarcoidosis like granulomas from those who were involved in the World Trade Center disaster as well. Other specific kind of more metals exposures that have been noted to have associations with sarcoidosis include titanium, other metal workers, aluminum, and actually silicone, specifically due to silicones, what has been seen with silicone with foreign body granuloma inflammation. Others include agricultural employment, insecticide work, mildew exposures, building materials, gardenings. However, with a lot of these, case reports, studies with associations, there could be, associations due to just primary granuloma formation from the exposure itself, or sarcoid-like diseases such as hypersensitivity pneumonitis or direct granulomatous disease, as seen in chronic beryllium disease, which, interestingly enough, the difference with the granulomas seen with beryllium do not have high amounts of the serum amyloid A compared to sarcoidosis granulomas. Given this, it can be seen that there's likely multiple different pathways for sarcoidosis like granuloma formation, and kind of can go in different directions as well, depending what the underlying mechanism is. In terms of, unfortunately, it's going to be very quickly, there's seemed to be a case in terms of genetics due to the amount of, oh, you know what, I'm going to go back for a second because I don't want to skip this portion, which is the self-antigens. There seems to be also a thought process of an infection may trigger some further immune response to self-antigens, such as what we see in rheumatic fever with group A strep. And some research had shown cross-reactivity of mycobacteria to tuberculin, desmin, and vimentin, as well as sarcoid being associated with other autoimmune diseases. Samples from BAL with specific HLA-DR3 patients have shown peptides and antibodies to ATP synthase, tRNA synthetase, and vimentin, which is interesting as vimentin is a constituent of the cytoskeleton. It's shown a portion of its peptide sequence to fit into the HLA-DR3 binding pocket, and also promotes, has been shown to promote IFN gamma production from T cells derived from those sarcoidosis patients. So, sorry, going back now to the genetics, and again, very quickly, there seems to be a lot of evidence towards, sarcoidosis in family members, familiar clustering, with the ACCESS study showing 5-fold higher development of sarcoidosis in siblings. So it was then looked at in terms of possibly underlying genetic reason causing this. Because of the prior history of antigens, the HLA class 2 and 1 molecules were believed to play an important part. Early research in the 90s, like the sarcoidosis map, which looked at Italian and Czech population of sarcoidosis patients, did show specific alleles having association and actually specific phenotypes, including early onset, late onset, and sarcoidosis restricted to the lungs. Actually, here at Henry Ford with Dr. Iannuzzi in the early 2000s, we had our own sarcoidosis population in African American, which we were also able to find association with the HLA DQB1 and D1B1. And even further studies have shown kind of supporting the concept that immunogenetic background may at least partially play account for the clinical heterogeneity of sarcoidosis, with different alleles with different forms, such as chronic sarcoidosis, if we see here, Lofgren, uveitis, and actually, as was said in the prior, Japanese cardiac sarcoidosis specifically. Very quickly, there was further evaluation of these genes, these MHC genes and alleles, but they did not have a kind of a unifying kind of diagnostic or prognostic area with the genetics. So further, with further understanding of immunoregulatory pathways that we found, there's been further kind of genetic wide array association studies and genetic studies looking at new genes and new pathways. And knew both SNP and other mutations had been found. And again, very quickly with all these kind of newer genetics that have been associated, a few of these genetic mutations in SMP are seen in pathways such as regulatory genes for T cell activation, apoptosis or proliferation pathways, T cell immune response, or even receptors for activation of Th1 and Th17 pathways. So to kind of get the takeaway of this, with the continuous sarcoid granulomas, you likely need an initial response to a trigger, such as an infection or antigen, a predisposition with a genetic mutation or specific alleles, and then all this causing abnormal regulation of the inflammatory pathways, allowing persistent granulomas, and as well as persistent ventral fibrosis. And with further understanding of the abnormal regulatory pathways and regulation of the inflammation, this will likely lead to more guided treatments and possibly expected response, and even understanding the different phenotypes within sarcoidosis. And to leave off with this, the final part at the bottom, as you can see, there's kind of multiple different abnormalities that can happen within the immune pathways that can cause the sarcoidosis, granulomatous disease. With that, thank you to Dr. Bradley and Dan. And if there's any questions, you can ask me after, or if Dr. Bradley has any.
Jonathan, thank you for that. It's a very concise discussion on a complex topic. So I appreciate you going over that, and definitely enlightening, and hopefully will help us in the future get more directed treatments to our sarcoid patients. And so with that, we're going to go ahead and move on to our final discussant with Dr. Ouellette, who's going to talk about some of the treatments for sarcoidosis and what's been coming over this.
Hi, you should have this is Dan Ouellette. You should have my screen in front of you now. I'm going to talk to you today about sarcoidosis management. I've been fortunate to be able to be part of an international panel that's developing a guideline for management of sarcoidosis, and this guideline should be available in the next few months. It's currently undergoing peer review. During today's talk, I'm going to share with you some of the strategies and algorithms that we've developed for treatment, so that hopefully you'll get a head start on managing your patients with sarcoidosis. I have some disclosures listed here for you, mostly with relation to COPD work and nothing that is related to sarcoidosis. Our goals today are going to be to learn about indications for treatment of sarcoidosis, to review the use of immunosuppressive agents in treatment, and to talk about some novel therapies that are being used to treat some patients with sarcoidosis. So I always like to involve patient cases and scenarios, and I'm going to have some cases for you today. And most of these, with only mild revisions, are taken from people that I've taken care of. And I do have a couple of embedded questions. We don't have an audience response system, but I'll ask you to reflect on the questions that I pose for you and think about what you might answer. So this first patient is a 54-year-old woman that you're seeing in our pulmonary clinic, and she's referred to you because of a mild cough. She comes from another healthcare system, and she wants to start being treated here for sarcoidosis, a familiar scenario. Her medication has been Imuran azathioprine, 100 milligrams twice daily for 5 years. Her pulmonary function tests are normal. She has chest imaging that's showing upper lobe chronic fibrotic changes, relatively mild. Calcified adenopathy is present. And you examine her skin and look at her eyes and measure her serum calcium levels and her creatinine, and all of those things are normal. You don't have any pathology on record. She perhaps tells you that 20 years ago, she thinks she might have had a biopsy, and she's got quite a few comorbidities, including high blood pressure and diabetes. She's obese. She's an active smoker. So I'd like you to reflect on what you might do next with this 54-year-old woman, would you switch her from azathioprine to methotrexate, 10 milligrams a week? Would you continue the azathioprine and arrange follow-up in 6 months? Switch from azathioprine to oral infliximab at 3 milligrams per kilogram dosing, or stop the azathioprine and counsel smoking cessation with 3-month follow-up? Think about what you do. What I would do for this patient is the last, and I'll tell you why. For one thing, many patients with sarcoid have a remitting course and their inflammation resolves and they don't require further treatment. And so I think that stopping a drug like azathioprine and monitoring the patient over a relatively short interval is very helpful. These patients, when we see them, often have other comorbidities that could be contributing to their shortness of breath symptoms. And so I think you should address those things as well, because it may not be the sarcoidosis any longer that's causing symptoms. I think 6 months is too long to monitor treatment. I think if we're going to use strong immunosuppressive agents in patients who have a serious illness, they probably need shorter, closer follow-up than every 6 months. I think if you have somebody who's been on treatment and who is so stable that you think they can be followed up at longer intervals, you ought to reflect on whether they still need treatment or not. And most of our immunosuppressives are going to require monitoring in short order. I don't think that switching from Imuran to one of these other drugs is the best choice either. The drugs that we use to treat sarcoidosis all are very potent medicines, and they all have serious side effects. Most of you know about all of this information, and I'm not going to go through all of this, but I would say that the prednisone that we commonly use is a toxic drug with many, many side effects. Methotrexate depends on renal clearance, and you should be extremely cautious in using this drug when people have any degree of renal insufficiency, especially at first. I monitor LFTs and white blood counts every 3 months or so to make sure that these patients are stable. And on other drugs like infliximab, these medications require monitoring closely also. So all of these medicines, if you're going to invest in following them, require close follow-up. I do think that patients with general sarcoidosis are good general pulmonary patients that a fellow could follow in the clinic, but if you're going to do that, I think you need to invest in close follow-up with your patient. My second patient is this person, a 30-year-old Black man who's admitted to hospital with shortness of breath, cough, and a right upper lobe infiltrate. His symptoms have been present for several weeks. He's reported a fever at home. He works at the post office, and he is a National Guard reservist. He recently returned from desert warfare training in the Mojave Desert. He's a non-smoker. He has a negative HIV, and his chest X-ray and CT scan demonstrate bilateral hyaluronidenopathy and right upper lobe airspace disease. His physical exam is normal. He has a normal ionized calcium level, and on bronchoscopy, he has a normal exam. EBUS biopsies demonstrate non-caseating granulomas in the mediastinum, and there are no organisms identified on pathologic section. What would you do? Start methotrexate 10 milligrams a week, prednisone 40 milligrams a day? Would you test him further, ordering a quantiferon gold test, fungal serology, send cocci serology to a reference lab, or would you order a lymphocyte transformation test? My choice would be to order more testing, including testing for specific infectious agents. All of our treatments, as we've just mentioned, have serious side effects. Many of them have not been clearly proven to change outcome, and they all require monitoring. So being in a hurry to start these medicines is not always the best plan. Furthermore, sarcoidosis is a diagnosis of exclusion. And you have to exclude these infectious diseases such as those listed here. This particular patient was a real patient, other than the fact that he was not a reservist but an active duty soldier, and he had coccidiomycosis. Cocci is very, very hard to identify in a tissue specimen. You need to have serologies. Your best serologies are going to be from UC Davis. I sent serologies to my local laboratory because that's what my hospital wanted me to do. They were negative, and 3 weeks after starting prednisone, this patient had coccisepsis. So you have to be very careful and rule out these other conditions and be cautious about that. If you know that a patient has sarcoidosis, prednisone is a good choice for starting. The lymphocyte transformation test, of course, is a test for somebody who might have borreliosis, and that's a good test in that setting. So for me, and one of the most important questions that I want you to take away from my talk today is that your most important question may be, should I treat, and not how do I treat? Think about that with all of your patients. So let's talk about strategy. One of the strategies that we're going to be talking about today is to assess your patient in terms of how much danger their sarcoidosis may pose to them. So if a patient has sarcoidosis but doesn't have signs of clinical danger, that is, their chest x-ray is the only thing that's abnormal, they don't have any symptoms, you may not need to treat these patients. If they don't have danger but have impaired quality of life, for example, if they have dyspnea, they have cough, they have mild skin problems, they have mild joint symptoms, stable chest x-ray, they may require treatment, but they don't definitely need to require treatment. If they have danger, and I've listed some of those things here for you that are associated with danger: progressive respiratory symptoms, deteriorating PFTs, ocular, neurologic, cardiac disease, disfiguring skin problems, or hypercalcemia. They may need to have treatment. We're going to go through a few case scenarios and use this algorithm for describing how you might take care of your patients. So the first patient scenario is a 28-year-old woman who has a cough for 2 months, a skin rash for a week, and has fevers, fatigue, sharp chest pains. Her serum chemistries are normal to include an ionized calcium. PFTs are normal. You've sent her for bronchoscopy and she has non-caseating granulomas, and your infectious serologies for her are negative. Her chest x-ray shows bilateral hilar adenopathy, and her skin examination shows findings consistent with Erythema Nodosum. So what do you think about the scheme as applied to this patient? Well, to me, her diagnosis is pulmonary sarcoidosis with enodosum. She doesn't have danger, but she does have an impaired quality of life. And my treatment choice for her would be to use prednisone at a modest dose, 20 milligrams a day, to monitor her course. That would be her initial therapy. The algorithm that we're going to develop for our guideline and in its pre-review is displayed for you here for immunosuppressive therapy for pulmonary sarcoidosis. This algorithm is color-coded for strong quality evidence or strong recommendations, for conditional recommendations, or for those in pink that are just expert recommendations. The left-hand column is for patients with no danger, and you can see that the best choices here are often for no treatment. If you have a patient with pulmonary sarcoidosis who doesn't have danger but has an impaired quality of life, your best choice may well be to start with glucocorticoids at the lowest dose possible. If the patient has significant side effects, or if they have continued active disease or relapse, you might choose a second-line agent that is listed in the expert recommendation box next. Methotrexate is listed at the top of that list because it's probably the preferred choice. If your patient instead would have pulmonary sarcoidosis with danger, you should use the right-hand column, which gives a strong recommendation for using glucocorticoids at first. In this group of patients, methotrexate or infliximab in that order would be good choices if the patient has glucocorticoid side effects or if they have continued active disease or relapse. Here's our second case scenario for treatment. A 40-year-old man with biopsy-confirmed sarcoidosis 5 years ago comes with peripheral edema and dyspnea. He was treated 5 years ago for sarcoidosis with 6 months of prednisone. He has a confirmed biopsy in the past. He has a BNP now of 1200, an ionized calcium level elevated to 1.6, a chest x-ray that shows a prominent vascular pattern, evidence of bilateral effusions, as well as adenopathy, bronchiectasis, and airspace disease. The echocardiogram that you've obtained shows the 25% EF on the echo, and your cardiology colleagues have obtained a cardiac PET for you that shows positive finding for sarcoid-like inflammatory changes. In terms of our schematic, where does this patient fall? To me, this is a patient with cardiac sarcoidosis with multi-system involvement, and they clearly fall in the danger category. This patient, from my perspective, should be treated with high-dose prednisone initially and have an AICD placed. And after the initial treatment, we might consider very strongly combination therapy with prednisone and methotrexate. This is the algorithm that we've developed for treatment for cardiac sarcoidosis. And the most important thing that I would suggest to you that's a strong recommendation from our group is that these patients should be assessed and evaluated with your cardiology consultants to have a pacemaker placed and an implanted cardioverter defibrillator as an important first-line therapy. And I think that's a very important thing. The first choice of drug should be glucocorticoids, but you should give early consideration to combination therapy in this group, and the first choice to combine with glucocorticoids would be methotrexate. There's less evidence for the other agents, and the agents at the bottom of the list, such as infliximab, should only be used if you're consulting with a specialist in this area who's familiar with their use, because in some cardiac patients, this may not be a good choice therapy. Our third scenario is this woman, a 35-year-old with a facial rash. She has biopsy-confirmed sarcoidosis and facial findings on her skin exam consistent with lupus pernio. Our dermatology colleagues have treated her with topical steroids, oral prednisone, and methotrexate, and she has normal pulmonary functions, a normal echocardiogram, and her ionized calcium level is normal. So although she may not have life-threatening disease, when I apply my scheme, I think this is a patient who has probably no danger, but clearly her quality of life isn't impaired. She has cutaneous sarcoidosis. She's already failed topical treatments, prednisone and methotrexate. Often these patients have been treated with hydroxychloroquine also. And if they've failed those initial treatment choices, infliximab is often a good choice. This is our algorithm for skin sarcoidosis and the use of immunosuppressive therapy. And we want to try topical glucocorticoids, prednisone, and hydroxychloroquine early. But infliximab is a good choice when patients fail initial therapy. Bob Boffman produced this study in 2015. And what they looked at was a sarcoidosis activity and severity index. And when you look at the element of this test, specifically for desquamation, treating patients with infliximab versus placebo, granted a very small study, there was clinically significant improvement in desquamation in the patients who were receiving infliximab. In this same study, here's some data looking more closely at the desquamation score after 24 weeks of therapy, showing that the patients being treated with infliximab had improvements. Sarcoidosis treated with infliximab, when sarcoidosis is multi-organ system, may also have other benefits. This study by Mark Judson in 2008 looked at a score called the EPOST score, which is a score that assesses extrapulmonary organ involvement. Most of these patients had important cutaneous sarcoidosis. So all of the extrapulmonary elements were not manifested in this small population of patients. But using this extrapulmonary organ system score in treatment with infliximab versus placebo, there was clinically significant improvement in this score by using infliximab for treatment of these patients with multisystem disease. So infliximab is a good choice for many patients who have failed initial therapies and have multisystem disease, especially cutaneous disease. This is one of my patients that's a complex patient and shows how difficult it can be to treat patients with sarcoidosis, and also how challenging it can be to choose therapy. This is a 40-year-old man who has had intractable headaches as his only symptom. He had an MRI of the brain that was felt by my neurology colleagues to be consistent with sarcoidosis. His chest x-ray and his pulmonary function tests were actually normal. When we did a chest CT scan, he had sub-centimeter nodes in the mediastinum that really were not enlarged. However, when we sent him for an EBIS, he had biopsies showing lymph nodes with non-caseating granulomas. His brain NP, ionized calcium level, quantiferon gold, and fungal serologies were all normal and negative. He did have diabetes with chronic kidney disease, and his creatinine was 2.0. And so he had been treated with prednisone, but he hadn't improved. His headaches had continued. His glucose control had been worsened. When I evaluated him, I was concerned about the use of methotrexate given his creatinine of 2. Where does he sit on this scheme? I think that he's in danger because he has neurosarcoidosis with multi-organ system disease. And I chose to treat him with infliximab. The points here are that neurosarcoidosis is a serious condition. His treatment is likely going to be prolonged. Glucose control with steroids is going to be problematic. His methotrexate is relatively contraindicated with his chronic kidney disease. Realize that controlled trials for this group of patients with infliximab does not exist. When you look at the algorithm that we have developed for neurosarcoidosis, it looks like this, with glucocorticoids and methotrexate being your best recommendations. I was all the way down the ladder on this one and chose infliximab, which actually controlled this patient's headache and showed reduction in his problems with MRI of his brain. We have some other algorithms that we've developed for our guideline also. We will see patients who have sarcoidosis where their main manifestation is chronic fatigue. There are some recommendations about how to approach these patients. There have been 2 studies looking at different kinds of exercise training of the inspiratory muscles, and these studies seem to demonstrate improvement. Bob Boffman has also, in small groups, studied the use of armodafinil and d-methylphenidate in the treatment of this group of patients with some success. And so these are choices that you can think about in the patient who presents to you only with chronic fatigue from sarcoidosis. Another problem that sometimes occurs with sarcoidosis is small fiber neuropathy and related symptoms. And these patients can be complex to treat also. If they do have active granulomatous disease, clearly you're going to treat that. But if not, you can consider some other treatments such as GABA analogs or antidepressants. These have been used in small cases to treat these patients, but the data is not robust for any of these treatments. I finally want to share with you one study that I think is very interesting and I think needs to be looked at more closely in the future. This is a study that came out of Vanderbilt and it was the main author was Wonder Drake. And what they did was they took patients with cutaneous sarcoidosis. They had a small group, 30 patients total. 14 were randomized to an interesting treatment that included levofloxacin, ethambutol, azithromycin, and rifampin, a drug cocktail that we would think about using for mycobacterial disease. And then they treated the other group with placebo. So it was a prospective placebo-controlled study in cutaneous sarcoid looking at an antimycobacterial regimen. These patients had a mean age of 51. Most of them were actually female. They were largely white, and they had, most of them, 8 years since their diagnosis. 12 of these patients had concomitant therapy, mostly either prednisone or methotrexate or both. This is an example of this. The SASI index, and we already talked about that in regards to cutaneous sarcoidosis. And interestingly, the patients on the antimycobacterial regimen improved more than the patients who received placebo. And this is a a photograph of the lesions on one patient and shows after 8 weeks of treatment with an antimycobacterial regimen, the changes and improvement that this particular patient obtained with the antimycobacterial regimen. And so clearly this provides us with food for thought. It has not been a treatment regimen that has been tried in any other groups of sarcoid patients. And given the things that Jonathan talked about in the previous talk, it raises all sorts of questions, not only about the role of mycobacteria, but is there a role for assessing the microbiome in patients with sarcoidosis to learn if there are changes that antimycobacterial regimens might make. We also have to wonder, of course, about the anti-inflammatory versus the antimicrobacterial effects of these drugs. So we talked just a little bit about management today. My take-home points would be these: treat these patients only for definite indications. Make sure they clearly have treatment needed. Many patients don't require treatments. If you're going to treat them, monitor them closely for adverse effects. You should stop therapy after treatment for several years and reassess whether they continue to need it. You should assess patient danger of untreated disease and use those kinds of schematics to decide whether or not your treatment will be needed. There will be algorithms in the near future that will help you choose recommended agents for treatments of different groups of patients. Invite your friends to the party. Talk to our subspecialists because we need their help in managing these complex patients with multi-system disease. And be aware that in the future, we may come across novel mechanisms for this disease, and we may be learning more that may have implications for our treatment. This is the international group when we met for the first time about 3 years ago, and hopefully we'll have a guideline for you here in the near future. Thanks very much.
Thanks, Dr. Arlett. I really appreciate that. Did anybody have any questions? And so, you know, in the sake of time, I'll end it here. And I just want to say thank you again to all of our presenters. And I really appreciate everybody's time and everybody's participation in this. I really appreciate it. I think it went very well. Thank you.
Thanks.